My name is Ali Alvarez. I'm the Director of Wellbeing at Stanford Emergency Medicine, and I direct the peer support program in our institution. I'm really thrilled to help kick off the Stop the Stigma Emergency Medicine Month for October. Amongst us here are really great panelists. I'm going to ask each of you to introduce yourself. And if it's okay with everyone, we're going to be first name basis here tonight. I'll start off with Kyra.
Hi, everybody. I'm Kyra Reed. I'm one of the assistant program directors for the EM residency at Indiana University. I graduated EM Peds from Indiana University as well, and I head up all the wellness initiatives within our program at IU. Thanks for having me.
Yeah. Greg.
Thanks, LA. I'm Greg Goldner. I'm an emergency physician by training, but retired clinically 2 years ago. I head up our well-being efforts for our 79 hospitals, teaching hospitals in HCA healthcare. And I work with a lot of clinical psychologists and organizational psychologists as well in relation to a lot of the stigma work we're doing here.
Great. Sadia.
Everybody, just a very big honor to be part of this panel. My name is Sadia Akhtar, and I am the Senior Associate Dean for Wellbeing for Graduate Medical Education at the Icahn School of Medicine in Mount Sinai, New York City. And happy to be here too.
Great. Vicky.
Hi, everybody. My name is Vicky Zoe. I'm the Assistant Program Director for the UVM University of Vermont Emergency Medicine Residency. Like Kyra, I do a lot of work with trainee well-being, and I also have a specific interest in recognition and its relation to well-being.
Diane.
Good evening, everyone. It's great to see you. My name is Diane Kripko. I am Chair of Emergency Medicine at Medical University of South Carolina at Charleston, and I was our inaugural Director of Wellness many years ago before this was popular. But I've transitioned it on to someone else, but it's still my passion. So I just can't go away from it. So happy to be here, y'all.
I love it. Amanda.
Hello, I'm Amanda Deutsch. I'm the Director of Wellbeing at Thomas Jefferson University in Philadelphia. And I have the honor of being the SAEM Wellness Chair right now, which helps with the Stop the Stigma EM, and I'm so thankful to be part of this again. Thank you.
Yeah. We have Tanya. Do you want to introduce yourself?
Yeah, I'm Tanya Van Gorten. I'm a pediatric emergency medicine faculty at Rady Children's San Diego and UCSD, and I'm the wellness director for our pediatric emergency medicine division.
Oh, wonderful. Thank you. Hassan? It's okay if you're not able to unmute.
Hello, everybody. This is Hassan Shaggag. I'm an emergency medicine resident, and I'm excited to learn from you all.
Thank you. All right. So I'll start off with the first question. So this is a question for everyone to consider. So how can emergency departments optimize human potential by creating psychologically safe environment where faculty, staff, and trainees feel empowered to report mental health concerns? So specifically, what structures can we ensure that the feedback actually leads to meaningful improvements in well-being versus getting in trouble for speaking up?
I can probably start by just suggesting it's interesting looking at other specialties. So if you look at family medicine, part of their program requirements is that they actually have a psychologist on staff as part of their faculty. So if you go back and look at your family medicine residencies at your institutions, you'll most probably see that there's a PhD psychologist as part of their faculty. And I will tell you that having seen how that person interacts with the residents, at least at Sinai, all of a sudden you can tell the difference of how the residents are willing to talk to that individual and to really just tell them about the problems that they're having, not just about the department, but also reaching out to that person on a one-to-one basis. And so I think looking at other specialties and seeing what they do could be something interesting for us as emergency medicine physicians.
I like that a lot. So it includes personnel, like an intentionality with who do we have in our department, so that when we have conversations, not only do certain groups, certain people have the right training for it, and also the skills to navigate some of these conversations. Greg, go ahead.
Oh, I was going to say, I also think the first thing that came to my mind when you asked this question was how can we just continue to normalize talking about our mental health?
Any other thoughts? I was going to ask Greg. I know you've done something when you're when you're a PD and a DIO specific to psychological safety regarding mental health concerns.
It's interesting because when we're talking about psychological safety, there's a number of things that actually impair the residents from reporting. There's both internal and external stigma. So there's two different types of stigma. And what we're finding actually is that a lot of people don't have a lot of external stigma as much anymore. That's seeming to go away. There's a lot more internal stigma, meaning I'm weak if I do this kind of stuff, which is interesting. And then there's the depressogenic problem where people who have depression generally have less, the more depression they have, the less likely they are to ask for help. And it's not a stigma issue. It's actually a depressogenic schema problem where they don't believe asking for help will result in help. And so that's a real problem because it means the most depressed individuals will not ask for help. And so that's where opt-out kind of strategies, where you do things to not ask them, if you need help, here's what you do, are most helpful. And we certainly did that in some of our programs.
So part of that is understanding what are internal structures that prevent us from reaching out for support. I think one of the things that I'm hearing as well is this idea that maybe somebody has to, and maybe I'm wrong here, but there seems to be this notion that you have to have a pathology or a mental health problem in order to seek help, versus just the idea that seeking mental health support is simply just a way for us to be well. I wonder if people can have some thoughts on that.
Well, that's the challenge, right? Because we tell folks that if you're diabetic, you're going to go and see your endocrinologist and make sure that your finger sticks are going to be fine.
Yeah.
And if you have a heart condition, you're going to go follow up with a cardiologist, or you're just going to go to your primary care to have your annual sort of health assessment done. And I think that's the trouble. Like, I feel all of us, at least I know I'm guilty of this, that I will put my health after the health of my family and friends. And I think if we can flip the switch a little bit and say that maybe we just all need like maintenance and an annual sort of checkup of our mind and body, and not just feel that it's something that needs to be addressed when we are in crisis mode. And that's where the issue is. Like, how do you get people to understand that our mental health is just as important, and maybe even more so important than our physical health? And how do we maintain that sort of maintenance of making sure that someone's checking in on themselves?
I like that a lot. Vicky, I see you unmute.
Yeah, I was just gonna say, I definitely love that idea. And what I notice a lot in this generation of medical students that I'm working with, and even some of our younger residents, is that they are very open about saying, I'm going to see my therapist this day. I have XYZ appointment. But then I think in leadership, I don't see that among faculty or attendings. It's not something that we talk about. And
Yeah.
I think being able to set that model, that openness is necessary, and it is part of our health maintenance, is a really important message.
Yeah, thanks for bringing that up. And certainly there's some generational changes here. By the way, I just want to pause and acknowledge Dr. Diane Gorgas for joining us, the ABEM president. Thank you for being part of this conversation. It means a lot to get the support from ABEM and also you being here.
Yeah, thank you. Just, I'm going to be a fly on the wall and looking for opportunities that we can lean in and help.
Sounds fantastic. Thank you. Amanda, I see that you're using your, I see Diane raise her hand, but I just want to acknowledge that, Amanda, I think you're using your phone now. So one of those will work. Diane, go ahead.
Yeah, LA, I just want to share a win with the group. Today we had our department meeting, and interestingly, I've had one of my employees has just not been herself lately. You just know it when they're just not. They called off a shift which is completely unlike them.
Yeah.
Productivity was down, just not quite right. And I was just, not that I'm happy that she was having difficulty, but today in a faculty meeting, someone had mentioned that, and another faculty member said, "Hey, I want to let everyone know that she's really been going through a rough time. So when you see her, make sure you support her and let her know that it's okay and we're there for her." And I was like, that is exactly what I want to happen. It's not someone to go, I had to pick up a patient because of X, Y, and Z, or she called out or left early. It was complete support from the group that just said, hey, she's going through a rough time. Let's just all support her. And then a second faculty said, hey, did she get referred to the employee assistance program, which is our health and well-being program? And it was just so nice. Instead of everybody dogging each other, it was really supportive. And I think that is exactly where we want to go with this.
I love how there's, number one, people are aware that there are resources out there. Number two, that when somebody actually shows some vulnerability, that it's met with support as opposed to focusing on yeah, I have to pick up more shifts or because of this person. I'm curious, I'm gonna use that as an opportunity to have this conversation about this idea of the stigma, right? I can imagine that people don't feel comfortable talking about this in such a way that, like, do we then highlight when people are calling in sick or they're unwell or they're simply not being themselves? How do we talk about it? Because I think well-meaning people are also trying to not talk about it because for fear of that's their privacy and I don't want them to think that we're talking about them. And at the same time, how do we encourage folks to actually, our department, to embrace this notion that we are part of a bigger system that actually will only function well if we do care about each other enough to notice these things.
I think if I can say this, that I think the vulnerability has to start with the leadership. And it may
Yeah.
be that one really strong leader who may have had some challenges along the way, who really just is so vulnerable in telling their story. I still remember I was in a medical board meeting at our institution, and our president, who is this phenomenal person who everyone admires and respects, and who's just a wonderful human being, stood up at the medical board meeting and said, I want to tell you about a story. And he proceeded to explain how when he was an intern, he went through about a depression and he was on medications and he had to seek help. And I was just floored. I was completely floored that here is the president of our institution who's telling the story about the challenges that he faced. And all of a sudden, you could feel how the tension in the room just died down and people were more softened. And you could see that there's an entry point for others to make comments if they wanted. So I personally think it starts from leadership and for them to show their vulnerability.
Yeah, that connects very well with what Vicky pointed out as well, regarding how perhaps our junior learners talk about seeing their therapists, and yet it's very rare for faculty, for leaders to talk about like when they went to their therapist and normalizing that conversation. And perhaps when we talk about things, it's not always that it's a bad thing. It's simply I just went to see a therapist because it's just been overwhelming, or I needed to just take a break because you know what, there's just a lot and we're dealing with a ton more experiences these days. Greg, I saw you on mute.
I was going to say that what you're beginning to see now is also the coaching side. And I was a therapist before, but my wife does lawyer coaching, and there's a very close connection between the two, very frequent. And I think you're finding a lot of people who are much more willing to talk about their coaching. But I love Victoria's comment too, and I agree with it 100%. And the military has seen this too, where you have senior leaders like colonels and generals saying stuff about them going to therapy. It changes everything. Everybody below them feels more comfortable. And it is a generational thing. I've repeatedly been in a big room of my faculty and I've said, I've done therapy for years. My wife and I have done marriage therapy for years. It's fantastic. Anybody else willing? And nobody, even though I know personally, because they've talked to me, I know they're in therapy or have done it, they will not raise their hand. And that's a generational thing, which is unfortunate. But I agree, as the generations come up, that will change. So I agree with Victoria's comment. I think it really does have to be discussed from the leadership level, but coaching will make this a little easier too.
Yeah. Amanda.
Yeah, I was just going to say, I love what Sadia was saying of sharing, especially from leadership, of their own triumphs over whatever they've had to overcome. And I think all of us, especially as we go longer and longer in our career, whether it's any actual diagnosis or just the ups and downs of life, we all have these things where I think of the Liz and Molly imagery of like going up the hill, and we probably all have like a Santa Claus bag of what we've gone through, of these things we've overcome. And some days are tougher than others, and we are reminded by that of a certain case. But I think it's just as much as we can, just like Greg and Vicky and Sadia are saying, bring it up and get leadership too. And it's why I try to, on every almost lecture I give to residents, somehow bring it up, even if I'm not my best. We all know I've broken up with therapists because it's not always the right fit, but still normalizing it so that we start to encourage our faculty and colleagues to really talk about it too, so that everyone that's maybe thinks it's still not the right thing to do for them is okay, maybe it is normal to seek this out.
I like that. There's a couple of things that you mentioned there. And I want to just connect it briefly to what Greg said, which is, again, in the conversations earlier about this mental health continuum, that you don't have to necessarily have an illness, that there's this spectrum of, there's one side where there's like low mental health and high mental health. There's also high mental illness and low mental illness. and to also consider other ways of getting mental health support, including coaching, including like commensality, group support, whatever that thing is that allows us to not feel alone, because a lot of these things that we experience can be very isolating. And also that's being connected with others can actually be empowering. And then the second part is what you mentioned, Amanda, which is now that we're talking about like each of our experiences of seeing a therapist or having a coach or other ways that we're addressing our mental health needs, I think it's important to explore that a little bit more. Like maybe we'll use this time to talk a little bit more about what does that look like when you reach out to a therapist and you know what, it's just not the right click. Like I certainly, Amanda and I went through this when we started doing the Stop the Stigma EM month. This is like 3 years ago now. I reached out to a therapist and I remember after the third session, the therapist was like, "Oh man, you're doing a lot." And I'm like, "I don't need you to validate like that I'm doing a lot. I don't need kudos for the things that we go through as emergency physicians. What I need you to help me is like help me navigate like all that traumatic things that I just had to deal with, because I'm about to go to another shift and I'm clearly still bothered by that one thing that happened in that previous one." And I think that's like a good example of sometimes we expect so much from the therapist and then it's just not the right click, or maybe we didn't have that understanding at the very beginning. And so there is a way to pivot that. There is a way to even switch therapists if it's not compatible.
I love that you bring that up because in my household, I have like extreme therapy jealousy because my husband's been with the same person for years and was like one of the first proponents when he met me in residency of how do you deal with the trauma you see daily as an emergency doctor. And so I have a lot of jealousy because I've had to, as I've moved, change therapists, and when it just doesn't work out. And I think that's part of what's helpful is just talking about that, because I think people think maybe there's this magical perfect fit, and it might take a lot of work, which is also hard when we only get certain days off, to acknowledge that this takes work and effort to maybe find a good connection that starts to really help us go through what we're going through.
LA, real quick, one thing I think that's important to recognize as someone who's trained in therapy in the past is that they don't know a lot about medicine. There is not a certification. And actually, SAEM could do a lot here in coming up with a just-in-time training sheet for therapists. So we've been working with that with our therapists here to create, and I've got a just-in-time training sheet for resident and fellow physicians so that a therapist doesn't say something like, "Why don't you just change jobs?" And that's happened previously. And they don't understand. Or how come you're not working? You should be working out an hour a day because that's been shown to be good for mental health. They say things that disconnect the transference. And emergency medicine is different than dermatology and pathology, right? And so SAM would do well if they could come up with a just-in-time training sheet, for instance, that talks about not just the basics of physicians, but what's different about emergency medicine, the compartmentalization that's impressively severe in emergency medicine, where you can walk out of a room a child just died in and have to immediately change mind, compartmentalize that. That's very different than other specialties that deal with a lot of stuff. So anyway, that would be a work product that would be really interesting for SAM to put together.
Yeah, and also I want to remind folks that like I love this conversation, and also because this is in partnership with every single national organization in emergency medicine, like people are smiling because this actually, I can see this as a tangible thing that we can do. We do so much to educate our patient, but we don't do a whole lot on how can we like actually educate those who are trying to help us so that they can be successful in their role, and also we don't get frustrated, especially if it's taking us like several weeks or months to finally reach somebody, only to realize like a lot of these pushbacks or challenges. So I love it. Any other thoughts on this? Kyra, I see on you.
I do. Thank you. This is such a great discussion so far. So as I'm listening, I'm thinking of this in stages, and this is how we approach it at IU too, is setting the stage even before residents arrive. We set the stage with expectations. We do that all the time in EM, right? Like set expectations, what you want on shift from your learners. So set expectations for what you as a group think mental health access should look like. And then you set the stage for modeling that. So it's like setting the stage and then modeling it. So doing what you preach, so you don't look like a hypocrite in what you're saying.
Yeah.
And then closing the loop with feedback and acting on that concretely with summarize data helps. And I know we're going to talk about that probably later, but data is really powerful in showing what we've done, what we've listened to, and here it is. And so those are the phases that I think of. And so setting the stage before even residents step on campus day one with, hey, here's what we think, here's what we offer, here's what we're going to do, here's what to expect. Then they arrive. And so we do, for example, an intern orientation. We have a month. I think most places do. But we have a wellness and mental health day where we literally talk about everything that we do and we model with stories, like you all were saying. Here's what I went through. Don't expect maybe the first time you meet with a therapist to maybe be the one. It might take some time. It did for me. So please don't give up. And then kind of setting up opt-out counseling, that's been really successful for us. So that's the concrete things that you prep the stage. You have concrete things ready for them so they don't have to think about it. It's not like, here's a resource if you need it. You're like, hey, you should have this from day one because our jobs are hard and this will be in parallel with your training. So just like you do ATLS, just like you are scheduled during your orientation for SIM, just like you have shifts, right there's your counseling session because it's just as important. So that's how you normalize it, by creating that opt-out sort of strategy. So we've been pretty successful with that. And then you have multiple touch points. Everybody's different in what they want, right? Maybe for some people, therapy isn't what they want. Maybe it's coaching. So you set that up, which we have too. And then maybe peer support, maybe a group models. Peer support groups are the way. And you just set the stage for all the touch points that you have that tell people, hey, they're not just all talk. Like they have stuff. And then you get data and then you touch back at the end of the year and say, here's what we've done. Here's where we're going. You don't like this, we're going to change it and go on from there.
Thank you for sharing that. And I love that there's many aspects there, right? There's not just one solution to this thing that we're trying to address. And I also love how you have a day dedicated to it so people can all experience it and it's an opt-out event. Amanda, I saw you were going to say something.
Yeah, I think especially with the people I know are on this panel, my question from what Kyra was saying was, how do we do that when it's not an orientation month, when it's faculty members that have been in the same emergency department that maybe really could benefit from some support, but don't know how because they've tried and they're like, it was awful. I didn't want to ever try again. So I love that of what we're doing, and I hope that we keep doing for residents. But I want to know, what should we do in our shops when we can't even convince maybe those faculty members that we think could really benefit from this?
And just to piggyback on what Amanda said, I think in my particular role, I feel that thankfully, with the ACGME and with all the EM organizations, I think a lot of attention gets placed on GME well-being.
Yeah.
So I feel like because of the ACGME requirements and the opportunity for us to actually have resources for residents and fellows, I definitely have felt over the last several years, a couple of years, that faculty are being left behind in this well-being space. And we all know that faculty well-being has a direct impact on resident fellow well-being. And so I'm just like, I'm looking at Diane to see as a chair, which again, I've always been so impressed by Diane's leadership and knowing that if you have a chair like her, that you could walk into her office and be like, I'm not doing well. I don't know what the resources are. Can you help me? I can totally see that if I was one of your attendees, you would take care of me. I wish we could like clone you, but I know that there are many
Thank you.
chairs. Unfortunately, there are departments where it may not be that supportive environment. So just wondering, maybe the chairs have to do something, or maybe we have to do something for the chairs.
Agree. So first of all, thank you, Sadia. That's super nice. I would not have you walk into my office. I would have you call me directly and we would meet like outside of work, because I think work is a lot of the stress inducing environment. So it's good to get away from that to talk. But to your point of how do you reach people? I would say, first of all, I tell all my folks, you can call me 24/7. And I did have a former resident one time call me at 6 a.m. on a Saturday, and it was very odd. I looked at my phone, I'm like, this is such an odd time to call me. And she had just dealt with, as I think Greg said, she dealt with a pediatric death and just could not, on the way home, she said, I can't get away from it. And it was awesome. She called me, and that's what I would want. But I think one way to normalize it, and I haven't done this, but boy, it got my wheels turning, to have someone from the organization who offers either EAP or peer support or whatever services you have come to a faculty meeting just to reintroduce what's there and to put a face with the email link or the website, just to have someone there to say, hey, if anyone needs help, please call me, call my office, call this, whatever. It's tough to reach. And I'm going to say it's tough to reach old people, especially like me. There is exactly why we're here. There is a stigma around this. This is for the very close to boomer. I am a boomer at heart, even though I'm one generation past that, but I'm a total baby boomer at heart. So you do not talk about this. You do not admit this. You do not talk. So it is tough. But I think that is it. I think we just have to get people in, and we have to do it repeatedly, not just once every 4 years. We have someone come to our meeting and say something. It should be almost, gosh, like every other month, if not every month, you put up a slide. You know, I talk about philanthropy every month. Maybe I should have a slide that says, hey, don't forget, here are the resources, everyone. If you need something, here they are. So just some thoughts on that.
It's a great tangible thing, Diane, that you shared, which is maybe some intentionality in faculty meeting to just highlight. One of the things that we do in the Physician Wellness Forum, for instance, is there's a doc. Amanda, you probably have seen this. Like the doc is like half deflated, and so just it's a checking in, like how are you doing, right? And it's like 1 to 10. You don't have to tell me. And then the next slide is like, it's really tough being a doctor. Here are some resources out there. Please screenshot this. Maybe not for you, but like for colleagues who may be going through this. So again, like sometimes when we use language like this may not be for you, but just take a picture, because at the very least they have it and they can also share with other folks. Greg, I saw you unmute.
Yeah, I was just going to say our mental health communications folks that we work with, so we have a lab that works on mental health communications, will point out exactly what you just said, which is that especially in depression, but in other things too, calling out that maybe you go to see a therapist so that you learn how to do that and you can communicate with your residents. So I've got at least one of our programs out there that's done an opt-out in faculty. And what they did is they actually booked everybody essentially and said, we're doing this for our residents. If it helps you, great. But that's not why we're doing it. We're doing this for our residents so that you can have that experience and be able to be that older mentor to say, hey, you know, this is what it's like, and this is the process for doing it. And they had a really good response rate. I was very impressed by that. And what we know from other studies is that initial contact with a mental health provider decreases thresholds in the future. So even if they didn't need something now, the fact that they went through whatever your process is and figured out how to do it, we use Doctor on Demand or other things, is really helpful. So you can do it, opt out also in the faculty, depending on the structure that you're all based in.
Can I just ask logistically, how would that look like? Because I think that part of the struggle that I've encountered, you've done a successful opt-out program for the entire institution, right? But oftentimes the resistance is, it's not because they don't want to, it's actually there's just a shortage of mental health specialists that's going to be able to provide that one-on-one care for every single physicians in training. How do we navigate that?
Yeah, there's a couple different ways to do that. I agree with you that it's resource intensive. So if you have your own folks that you're paying out of pocket, for instance, that can be difficult for large institutions. We have 5,400 residents. So that would be pretty hard to do everybody. What we typically have done, though, is in the study that you're talking about that was published in JGME, we had some funding that we used to pay for some therapists that we got at a clinical psych training program, which are much cheaper, actually. And so if you happen to go Google it and see if you have a PhD or PsyD training program nearby. They often have cheaper resources, and the residents actually enjoy often working with people closer in their age range.
Peer, yeah.
So you can do that, but everybody generally has an EAP program. And so what you can do is work through that. It's a little more logistical time. And so typically you get one person who's the opt-in person, and they are concierge who helps work through the EAP kind of thing. And EAP is covered generally by your organization separately. And most people only do four of the 26% who ultimately go on beyond the first session that you schedule, most only do between 4 and 6 sessions. We know that generally people in this age range don't do long-term, once a week for 3 years kind of thing. They do solution-focused therapy.
Thank you for that. So what I'm hearing is there's a version of this where people can also, there's virtual aspects of it that makes it accessible. And also like maybe checking out some resources within your institution if they can collaborate for a negotiated rate. Amanda.
I was just going to say, everything that was just said is amazing by both Diane and Greg, but also that idea of doing it for the faculty and wording it was really thought of as this learning tool for them to be better mentors, coaches, what we are for these residents is such a fascinating way to try to frame that for people. And I just think, I was imagining all these clicks and the modules we have to do annually at times, or maybe if places don't have to do it as often, but if you had to attest that you actually tried it so that you could speak to them about it, how cool of an idea that truly is to normalize it and make it a helpful tool. I just love what I'm hearing from everyone.
Amanda, we did it for patients too. So we mistargeted to the residents saying, you're going to recommend therapy for your patients your whole career. That's just a normal part of what you're going to do as an emergency physician. And if you've never experienced it and you know nothing about it, that's just disingenuous. So we said it was part of our curriculum. And so a little bit like in a PhD for clinical psych, they don't do this as much, but I had to do a bunch of therapy myself. It was just part of the mandated program. So we essentially said this is a opt-out mandatory part of your program as part of the curriculum so that you can help patients in the future.
The other side of that, Greg, if I'm going to push you a little bit, because I thought that work was really fascinating. It also allowed your trainees to answer honestly when they're asked, when they apply for certain hospitals that ask, like, have you been seen by a therapist? That the answer is no, because this is just part of their residency training.
Yeah, that's what we said. Now, the flip side of that too, and I hope everybody's already done this, is to go look at your own credentialing forms and peer reference forms. HCA converted every single one of our 187 hospitals and 300 other facilities and all our peer reviews to the Lorna Breen Heroes Foundation wording last year, so that not a single one of ours anywhere across the enterprise says anything. It says, are you currently impaired? It doesn't. What it used to say is, have you ever been under the care of a psychologist or physician, which is absurd. And so we got rid of that. So that's the other thing I would say everybody should go look at from a practical standpoint, like tomorrow.
Yeah. Kyra, I saw you unmute.
Yeah, I'm so glad you brought that up, because I was also going to say something about, even if you remove as many barriers as you can for people to accessing mental health, if they feel like it's going to affect their employment, they just aren't going to do it. And so that's what we did too. We recognize that this is very intrusive language on the credentialing forms. IU Health, redid all their credentialing forms. However, even from a residency side, though, we get credentialing forms from everywhere. And so I see the whole spectrum of appropriate to very inappropriate, intrusive questions. And so what can you do? Because, you can control what you can to advocate within your system. But that's what we did, because we called it our curriculum. And we said, everyone gets access to this. Of course, they could answer however they want to, if they want to say yes or no, it's part of our curriculum. But we have a boilerplate statement that we put in the credentialing form. So if they ask that question, and then we'll put the boilerplate statement there that basically says, hey, you shouldn't be asking this question. You should consider rewording this. And I'll put a link in here that actually, if you want to read ours, you can have access to that. That's been really helpful. And we tell the residents that up front, because otherwise they wouldn't have even gone to their opt-outs if not. And I think that helps faculty to know as well, because I don't think until we started talking about it at faculty meeting that they realized that's now taken off, so they don't have to worry about that anymore. Another way in terms of faculty engagement is I started talking at faculty meetings, or every chance I got, like at division meetings and section meetings and things like that, to talk about the resident data. And they got people talking, for example, well, how do we make this work for faculty? And it's created that open dialogue about it. So that's also powerful.
Yeah, thank you for that. And I see the document in the chat. I'm going to click on that really quickly so I don't lose it. And certainly, I think it's one of the better practices that we should disseminate and share with folks so that they can be inspired to tailor this to their own institution. Any other thoughts on this? I really love this conversation about how might we get our faculty, who may be a little bit more resistant actually than our trainees, to seek mental health care, to do it in service of their trainees, to go through it as part of learning. And then it may be connected to what Greg asked at the very beginning, for organizations to create like a tip sheet or some sort of training for mental health supporters, but also for us to survey what's available out there. Like, what are the common resistance that folks experience? And then based on that, like, this already sounds like a study. Based on that, we can gather, like, what are the common themes that people have encountered? What are obstacles for them to reaching out? It may be that like insurance will not allow it, or it may be that like XYZ, right? And if we can collate that, and as a panel, as a group of folks, like from different organizations, we actually have a nice answer that helps them navigate it. It may minimize a lot of these challenges. Any thoughts and reflections on that? That was an inspiring thread, so thank you. One thing that Kyra said as well, I think, is, and it's coming up repeatedly now, is that institutions have a role on how we ask folks whenever they're re-credentialing or credentialing specific to their mental health care. And again, this is why we're so grateful that ABAM is here, because they have done like many ways to make sure that we minimize the stigma, even at the ABAM level, that we support physicians seeking mental health support. But the challenge often is either at the state level, which the Lorna Breen Foundation has done a lot of work with. They're partners here for the Stop the Stigma EM month. And Diane, myself, and others are working on, we have a meeting coming up in a couple of weeks, so that like we're launching this thing that Greg, that you're doing, so that every emergency departments, and actually not just emergency department, every institution that has representation from these departments can ask, like in their credential department, and specifically look at, are these language that can be stigmatizing? Can we remove them, or can we give them these boilerplate language? I haven't personally gone through that whole process, other than I remember I got one from our institution. I screenshot it. I sent it to our peer support person. Listen, we talk about mental health support, and we are being asked to like do this. And so that was like within a year, like that disappeared. But I don't know like how other people would navigate this. So I'm just normalizing that also it may not be as easy. Diane, I saw you on mute.
Yeah, it's a little bit on a tangent, but just like when we talk about ED boarding, it's not ED, it's hospital boarding. The stigma comes from the word mental.
Yeah.
I think it's not health. It's not. So it would be interesting if we all together called it something else, like cerebral health, or something that takes away that word mental, because that makes it like this odd, ambiguous, and very stigmatized word, as we know, but to something that's very physical, cerebral health, or something else. It would be a big change, but what a difference on how people would view it.
Yeah, for sure. Like when we talk about wellness and burnout, there's a lot of buzzwords that we keep on changing. But I'm more of a believer as let's just actually talk about it and normalize, as opposed to like switching the names. Like you're right, like mindfulness. I try not to use the word mindfulness as much. I use self-awareness, because then whenever people hear mindfulness, they associate with meditation. And yeah, but you're right. Part of this is language.
And it's going to be harder to get an older crowd to switch that thought, that stigma. But
Amanda,
I hear what you're saying, but I still, and the connotations that obviously are around it, but I still want us to own that word, because it's also great, right? When you work on your mental health, let's be proud of what we're doing for that too. And I get what you're saying, because how can we get people of that generation that we're talking about, of those faculty members, of people to feel the strength in it? And I remember even with a patient that needed to be cleared for the police to take away, and they were like, well, you cleared them. And I was like, no, I'm still worried about another part about their mental health of this patient too. And we got in a big fight even for that. But it's like, we need to own that our mental health is part of just all of our health. But I'm torn on both ways, because I see what you're saying, but I also just am like, I want to own this and not let this word have that negative connotation.
I have a question to ask the group here about your thoughts, because I was just reflecting on the fact that as a prior program director, we all met with our residents on a semi-annual basis, checking in with them, making sure their procedures are done, that they're going over their CCC scoring, etc. And then one of the questions was always about their well-being, and to check in with them and to say, how are you doing, making sure that everything was okay, that they knew the resources. Again, I'm wondering if on the OPPE, or like the performance evaluation for a faculty member, is it intrusive if a chair sits with you, as they should, once a year to go over your performance eval, that they check in with you, and that it's an actual mandatory question that you have to ask your faculty member about, are there any stressors? Is there anything that the department can do, or do they need assistance with getting the resources that they need? So I'm just wondering if that is something that could be done without difficulty. I don't know what the group thinks about that.
Do you feel that it would create psychological safety or hinder it, I guess is my only question, because I love that idea. But I wonder if on the spot in those reviews, oh, can I say this? Can I say what I'm actually feeling?
Well, I was hoping that if they see that the chair is interested and has the will to help them and connect them to resources, that the well-being culture of that department would be that, yeah, I'm going to meet with my chair, I'm going to talk to them about my productivity, but I'm also going to have this psychologically safe space to talk to them about X, Y, and Z, about my stressors, because of the fact that it's been created that way, and that the structure of that dialogue between the chair and the faculty member has been set up that way. That's what we do for residents. So I'm just like, why
Yeah.
is it that we can't do the same for our faculty?
I can share that we have been doing this for the past couple of years as part of our annual review with our vice chairs and chair. And oftentimes, I think, as Amanda pointed out, it's the framing. The question is so vague that people focus on things that will help them get promoted and less about like personal stressors. And also, I can imagine that people will see it as like, this is not really the time for me to talk about my personal stuff when I'm talking to the chair. And I'm with my role, I get to meet with the chair every month, but like for some folks, that's the only time they get to meet with that person once a year. I'm torn. I'm curious.
I think, as I heard you say this, LA, and still what I was reflecting on of what I said to Sadia, I think it reminds me of like back in my college years of a coach sitting down with us, because we also kind of had that annual review, but there was one that was just a check-in of literally how were we doing, and she would laugh because she would say almost all of us would come away crying when she would just sit there silently and let us actually have a moment to be like, wow, we can honestly talk about that. And maybe it's just what you're saying of unfortunately asking for a second sit down with leadership, with faculty members, to have one only about well-being instead of the promotion side of it, so that it really does foster that second step.
I think the key is to having someone who's supportive. So imagine your chair
Yeah.
is not someone you feel comfortable talking to. That is going to create exactly opposite effect. So maybe the first step is educating chairs on, if you are not the right person for this, should there be someone designated for this?
I was saying, I just love that. It was like,
Having just come back from ASAP, I heard some horror stories of
Yeah.
some departments and chairs, and I was just flabbergasted. But you know what? And I'm not, maybe there are people in my department who wouldn't feel comfortable coming to me. I would hope they feel comfortable going to someone, but maybe part of it is, and we talk about this generation, chairs are not going to be 20 years old. They're going to be older. So it might, maybe part of this Stop the Stigma campaign is really educating the leaders in recognizing that they may not be the right person to designate someone, but to address it and to make it an open forum for it.
I love this, and also I just want to highlight this. So what I heard was there's two things, and we need to disassociate that. What Sadia recommending was like a once a year check-in with faculty and how they're doing is important. I think we can all agree with that. And that it doesn't necessarily have to be the chair. It can be somebody else in the department that people trust, and people can actually have a conversation with. And those two can happen. And both, I think if we can accomplish that in each of our departments, I think our departments will be much better. So thank you for those two threads. Vicky, I saw you unmute.
I was just going to respond to what you said actually about my initial gut response was I couldn't bring that up with my once a time meeting with the chair because I'm a younger faculty member. But then I remember as a resident, which wasn't that very long ago, that among my APDs and among my PD, there was that one person that I did feel comfortable having that discussion with. And it made me reflect on our peer support program. And I know many other institutions have the same thing, but having somebody that is a faculty member, but maybe more at your comfort level or level of experience, being able to have that person be a supporter, and oftentimes they're trained to also be a supporter, would be a really good thing to have and can be a better outlet.
Yeah, I like that a lot. And also, again, that highlights what we were just talking about, which is we don't have to have one person, because I can imagine each one of us, we have that one person to go to as well. It may be different from our colleagues in the department. So as we wrap up, Kyra, I see you unmute.
I just had a thought to kind of maybe split the difference too, in a way to standardize it, is you could potentially put in the pre-work. Because I don't know if everybody's departments do this, but you have some things you have to fill out, like a faculty annual review, and reflect on your own progress and what you've done. If you could add something in about reflecting on your own wellness, just to promote that self-reflection, and then that puts in there that we care about this, and hey, I'm open to talking to you about this if you would like to at your meeting. So that allows people to bring it up if they want. They know that they reflected on it, at least thought about it,
Yeah.
or they could choose not to.
I think people want to know that we care, and so as leaders, I think that's the message we want to share. And also, what I heard as well in some of the conversations here is that there are people, maybe it's us, who may be resistant to some of these like changes just because it's never been done, or it's because we're worried, or the resources might be overwhelming. But what I also like is this idea of, can we just talk about this? Can we bring it up, have a little bit of intentionality to talk about it? And maybe as a group, people will come up with creative ideas. Here alone, like Sadi asked a question, like a couple of people share their thoughts, and then now more ideas come up, right? Like, I think this is a great example of what psychological safety is. We don't necessarily have to solve the problem, but we can talk about it. We can talk about it enough so that like we can understand the problem even better, so the solution can naturally just come up. Like that, for me, is like very true design thinking way. Greg, I saw you on mute.
I was just going to comment that we don't have anybody from HR or legal sitting in here. And as you blend the person who makes promotion decisions with a question about how you're doing on well-being,
Yeah.
just be careful.
I love that perspective. And again, that highlights that it doesn't always have to be the chair to do that. So even as an investment, so I am very fortunate to be in a department where we have a role for it. Like we have a director of well-being that has like a funded role to actually focus on this, so that I don't have to worry about whether you're getting promoted or not. My responsibility is to be able to listen to you and talk through things, and not have to worry about like all the disciplinary things that may also be associated with some of these conversations. All right, so as we wrap up, I'm curious, I'm just going to ask each of you, what's one thing that stood out for you today that you really like? So that's number one. And then number two, what's one thing that stood out for you that you want to explore a little bit more to move this conversation going, specifically on how might we harness the human potential in our department and stopping the stigma on mental health? Who wants to start?
I can start because I think what Greg said really stood out about the faculty opt-out program. I think that's brilliant. If you can financially afford it and have the resources, like why aren't we doing that? I think it's a fantastic idea. It really puts it front and center for the faculty in the department to make sure that they're taking care of their faculty. And then I do this idea of having someone in the department doing the check-in for the faculty, maybe not a psychologist or psychiatrist, that person that they can go to if
Yeah.
there are any issues that they're having.
And hopefully they're empowered to actually help affect change, as opposed to just hearing all the things and not being able to do anything about it, because that's also probably worse. All right, who's next?
I can go next. I love the idea of getting just-in-time training for people to have specific therapy designed for not only physicians, but emergency medicine physicians and the unique challenges that we face.
Yeah, thank you. That's a great outcome. If there's one thing that we can do here, thank you. Yeah.
I'll go. I love Kira's idea of the intentionality of asking faculty for the yearly eval and
Yeah.
adding wellness in of their self eval. I had not incorporated that. I ask them, I'm like, how are you doing? Are things going okay? But to have them intentionally think about it prior to meetings. So I'm telling you, it's on my, I was typing it in as you were talking. It's on my list and we'll
I'm
happen
getting
this year.
goosebumps that we just made something like tangible that happened from this side.
I love it. Thank you.
All right, Diane.
And I just want to say that it really rang true to me that there is a little bit of a generational divide here when it comes to the stigmata of mental health. My husband is a college professor, and in the generation with whom he works, there is not the stigma associated with it. And I don't know if we grow that stigma in medical school and in residency, the same way that we grow emotional intelligence diminishes throughout training. But I wonder how early we need to intervene to not grow the stigma to the point where when you've been in a career for multiple decades, then it really does become a stigma, because I don't really see that in whatever the youngest generation of college learners is at this point.
Yeah. Thank you for sharing that. Go ahead, Amanda.
I was going to say, I'm just amazed getting to listen to all these amazing people. Truly, I'm thankful for everyone that was on this, that is out there making this difference. I think the one that's really stood out was I was laughing because it was intentionality and truly creating that training sheet. Since I can think of us talking these past 2 years of get those right therapists, how do you find that one? And what if we just made it so everyone could be the right therapist if we gave them the sheet ahead of time, gave someone a little extra homework, but they could then be the right fit for all of us. So I love this.
I've appreciated everyone's thoughts. I'm just taking it all in, and I think all of us are kind of fixers and solution oriented. So my brain's on fire, just going through all the potential solutions. But I do love that idea of standardization. I think is such a great idea, especially when we're talking about destigmatizing and normalizing.
Yeah.
So I love the idea of that flow sheet that people could, if they have no framework for it, having that here, if this, then go. I love that idea, just to have a roadmap for people to start somewhere. And you can't copy paste on what you have at every institution, because every institution's availability and resources are different, but at least starting that conversation, investigating whether you do and what you would need, and data helps that too. Hey, this opt-out thing works. Let's get it for faculty. Let's hire more therapists and counselors because it's so helpful. Things like that, I think, would be useful for institutions to realize and know.
Yeah.
So I appreciate it.
Greg?
I'm still thinking what Diane said, because we've been doing some research on, we just had a 1,400 person study that showed the hidden curriculum and psychological safety in medical school predicted depression in residency. How far back does it go? I agree with Diane. I think we begin training it in medical school, and then we push it pretty heavily in residency. The internal stigma that I'm weak if I do this, and I don't want to hurt my colleagues, and I don't want to, if I take a day off or something, it's going to hurt everybody else, and that's not a good thing. So I'm trying to think through that a little bit. I think you intervene in medical school and begin there. But the other thing is, I think what Victoria said I still would love to get a lot more mentorship and modeling from our senior folks. It just, that does seem to make an impact in other settings. And if we can just get this older generation, baby boomer and Gen X and others, to just say, yeah, I did therapy, and not freak out internally that somehow the world's going to explode if they say that. So that, I think, would be a big goal.
I love that reframe, that instead of perhaps focusing on making sure that certain generation needs to embrace mental health care as just a thing, but perhaps another way of looking at it is maybe leaning into their caretaking abilities and asking them, would you try this so you can model for the future generation to do it? Perhaps they're going to be a lot more willing and seeing the word mental health as difference, because then they're using it to help others as opposed to focusing on themselves. I am just so grateful for this time with each of you. I know each of you are so very busy, and you came here, share your expertise, and really kicked us off very well. So thank you so much. We will collate many of these things that you shared here today. I will be reaching back to you so that you can be part of how will be the next phase of this. And just really, truly wanted to thank you, each and every one of you. And Dawood, thank you for keeping us here and giving us the technology to do this. I look forward to incorporating the video that Dr. Gorgas created for us as we share this. Thanks, everybody. And I look forward to working alongside you.
Thanks for organizing and doing.
Bye.
Thank you so much, everyone. Bye-bye.
Good night, Al.
Thanks. Bye.